Diabetes affects people of all ages. Most forms of diabetes are chronic, and all forms are manageable with medications and/or lifestyle changes. Diabetes, prevention, diagnosis, and treatment measures. Tonight, On Call with the Prairie Doc.
Welcome to On Call with the Prairie Doc, health information based on science, built on trust. I'm your Prairie Doc host, Dr. Kelly Evans-Hullinger, and tonight we will be talking about diabetes. Diabetes is a chronic condition that affects the way the body processes glucose or sugar in the blood. Tonight we will discuss two main types of diabetes, type 1 and type 2. Early diagnosis and treatment of diabetes can help prevent serious complications such as heart disease, strokes, kidney disease, nerve damage, and blindness. Seeing a doctor regularly if you do have diabetes is important for monitoring blood sugar levels, managing medications, and preventing complications. Early detection and intervention can help prevent serious complications and improve overall health and well-being. Tonight, our discussion will focus on diabetes, and we will take your questions. This evening, we are joined in the studio on the campus of SDSU by Dr. Richard Crawford from Avera Endocrinology and Diabetes, Dolly Farm, and Dr. John Palmer from Monument Health Rapid City Clinic through Zoom. Welcome, guys, and thank you so much for joining us this evening. Happy to have you here. Dr. Crawford, tell us a little bit about yourself. How long have you been in South Dakota, and tell us about your job down there.
Yeah, so I'm an adult endocrinologist, originally from Illinois. Had relocated from Chicago to Sioux Falls about 12 years ago. My wife's family's here. She has roots here, and at that time, 2 young kids who are now older. And so I've been with the group for 12 years, and we see a variety of conditions, of which diabetes is by far and away the largest.
Yeah.
What we see.
Yeah. Great. Dr. Palmer, how about you? You've been in Rapid City for how long now?
I've been here off and on now for a total of 10 years. I'm a South Dakota native, actually grew up in Rapid City, and then came back after fellowship and was here for about 4 years. And then I joined Richard on the east side of the state for about 5 years, and now I've been back in Rapid for 6. Like Richard, we do adult endocrinology at my practice. I'm in Rapid City about half the time, and then I also go to outreach clinics throughout the Black Hills. And then also have a real busy hospital practice, and like Richard too, chasing children in between seeing patients.
Yeah, well, grateful for your time. Before we start our conversation, we invite you, our audience, to submit your questions for tonight's discussion about diabetes. Viewers can contact us 3 ways. Call 1-888-376-6225, send an email to ask@prairiedoc.org, or ask on our Prairie Doc Facebook page. We will work to answer as many of your questions as possible given the time available. Sometimes we receive more questions than we can cover, and we apologize if we do not get to your question. Your question will remain anonymous and no information is saved. Viewers can leave their name, email, or phone number to be entered into a drawing for our Prairie Doc publication, Perspectives from the Prairie, but it is not required to submit a question. The winner will be drawn and announced at the end of this program. Well, let's just start a little bit with some definitions and basics before we get to some viewer questions. What is diabetes? Richard, can you tell it, what defines diabetes?
Diabetes is a disorder where you have high blood sugar, basically. The 2 main kinds are type 1 diabetes and then type 2 diabetes. Type 1 diabetes, autoimmune diabetes. Type 2 diabetes, which is by far and away 90% the more common, is insulin resistance, also insulin deficiency. And when you lack insulin or you have insulin resistance, you get high blood sugars, and that then defines diabetes.
Yeah, but 2 pretty different at least initially, diseases between type 1 and type 2. John, what percentage of people with diabetes have type 1 versus type 2 in your experience?
Yeah, type 1 is obviously going to be far less frequent, anywhere from 5 to 10% of cases, depending on what we're looking at. The vast majority of patients, particularly United States, Western world, are going to be type 2, which is going to be 90% plus. And I would say the majority of patients that we're seeing in clinic are going to be type 2 diabetes as far as the diagnosis is concerned.
Yeah. And like, are patients coming in with symptoms that they think they have diabetes, or how do we find diabetes most of the time, John?
Diabetes is we find it all the time. Patients incidentally will find it, and we have a really busy hospital practice. Patients will come in, maybe have not been participating regularly with their doctor, or been seen in a while. Yeah. They'll come in with something completely unrelated, be it a heart attack, be it a stroke, maybe a pneumonia. And it's kind of an by the way finding, and they're maybe surprised that they even have it. And perhaps in retrospect, you start asking questions. They may say, I have been losing some weight recently. I've been more fatigued. I've been going to the bathroom more frequently, whatever it may be when you make the diagnosis. But I think, again, it gets back to the point of making sure you're seeing your doctor regularly and getting screened, because so many people are at risk for prediabetes or have type 2 diabetes without it. And so it doesn't always show up with classic symptoms. And so the screening purposes and following regularly with your doctor is so important.
Yeah. So John mentioned prediabetes. What's that, Richard?
Right.
Came up in our Q&A earlier.
So prediabetes, or sometimes it's called a compared glucose tolerance. It's basically what is developed before overt diabetes. And it's got fairly defined definitions: blood sugar 100 up to about 125. There's a blood test called a hemoglobin A1C, which is like a 3-month measure, and that might be 5.7 to 6.4. And but it's starting to develop the same complications or risks that someone with overt type 2 diabetes will have. And in the United States, it's estimated there's 97 million with pre-diabetes, 1 in 3 adults, and again, many of these folks don't know they even have that. Even those who develop overt type 2 diabetes, it's estimated that 25% are unaware that they've got the diagnosis. So just as John said, getting in for regular screening, especially if you've got a family member, first degree relative with it. If a woman has had like a 9-pound baby or gestational diabetes, that's a risk factor. Obesity, and certain ethnicities are risk factors. So getting in and getting screened and really being on top of early lifestyle changes, diet and exercise, and then perhaps medications if needed, but starting early and working on it.
Yeah, and so you mentioned family history. Is there a clear hereditary or genetic link in patients with type 2 diabetes, John? What do we know about
absolutely. Absolutely, we see a strong family history, and so many times you'll see people who may not even look like the classic patient that you would otherwise, feel would be at a higher risk, that will just have that genetic disposition to it. And so that's why it's so important to know your family history. And if you do have that family history, making sure you're getting screened regularly, making sure you're making the proper lifestyle modifications, be it diet, physical activity, to try to stave off that risk as best you can. But yeah, there is a very, very strong hereditary predisposition to it. And I tell my patients, frequently you have to understand that. And, it's not always fair, but we are all dealt the cards that we are, and we just need to make the best of it, understanding that.
Yeah, and you're right. I mean, in primary care, this is one of the things that we're doing for most of our adult patients. If you come in for your annual well visit, would be screening for diabetes, because it is so common. We're getting enough viewer questions, so I'm going to jump into a few of those. Let's talk about this one just because we kind of just mentioned it, Richard. We had an email question. I was diagnosed with gestational diabetes during pregnancy. Does that mean I might get diabetes later in life? What is the link there?
There certainly is a link, and it's been shown that individuals with gestational diabetes are at higher risk. And so, again, going for your regular checkups, getting periodic screening for that. Because that is such a risk.
Yeah, good. John, we had a caller who asked if my sugar and A1C levels are in the pre-diabetic range, so it sounds like they're getting monitored and they've been in that pre-diabetes range. How worried should I be about complications of diabetes, things like neuropathy, amputations, and other complications, which we might get to?
No, absolutely, and I think kind of Richard talked about that even a little bit earlier. Prediabetes to me and type 2 diabetes are the same diagnosis, essentially. It's just varying degrees of severity. And so when a person has prediabetes, we want to take that extraordinarily serious. And I think previously we maybe had a more laissez-faire sort of approach to it, where we maybe didn't take it aggressive as far as lifestyle modifications are concerned. as far as increasing physical activity, maybe even considering medical therapeutics now at this point, be it glucose lowering or sugar lowering treatments that we can do, or weight loss modification medications that we can use. So as far as the complications go, we can avoid all of those if we are aggressive with therapy, if we take it serious and we get it managed. But we do find that even some patients in the pre-diabetic range can develop things like peripheral neuropathy or the numbness and tingling that sometimes can happen. We do know that patients with prediabetes are going to be at a greater risk for vascular disease as well, be it heart attacks or strokes. So when you have that diagnosis, it's very important you're following regularly with your provider to make certain that we're being aggressive, not only managing the blood sugar aspect of things, but making sure your blood pressure, your cholesterol, all those other things that go along with it are being managed and being managed adequately.
Mm-hmm. Yeah, good. Let's see, we have an email question. I was recently diagnosed with diabetes. How many checkups should I be scheduling with my doctor? How often are you typically seeing your patients with diabetes? And maybe it depends. And I guess just I'd add to that question, is there anything else in the newly diagnosed diabetic that you recommend they do as far as appointments or anything, Richard?
Right. Well, and certainly if they're new to all of it, I'm sure they're overwhelmed with what they have to learn, both in terms of maybe counting carbohydrates or dietary changes, what their goals are for exercise. And we usually say try to aim for 150 plus minutes of moderate intensity exercise per week, and learning how to do self-monitoring. So, if they're fairly well controlled or easily controlled on 1 or 2 pills, maybe it's doing finger sticks. Otherwise, it might be using like a continuous glucose monitor. So usually if someone's fairly new to this, especially if they're uncontrolled, I like to see them fairly regularly, maybe quarterly, because about every 3 months that hemoglobin A1C is a good metric of how well they're responding to treatment. And being kind of aggressive to add more therapies if they aren't responding to one pill or they aren't responding to one treatment. I think that's the thing that we've learned, is that you don't wait 2 years to slowly add a second medication or make another intervention, that you need to do this aggressively and sometimes in combination therapy early on.
Yeah, and most places would have access, not everywhere, but hopefully most places, to things like a diabetic education, which is usually consult with a nurse and maybe learn how to use your glucose monitor and that kind of thing, right? And maybe the nutrition consult. So those extra things in a new diabetes diagnosis can be really helpful. Good. John, this is an interesting question. We talked about this on the radio show this week too. We had a caller ask, artificial sweeteners are sometimes controversial. Are they a good option for diabetic patients? So you have the patient who is a new diabetic and you find out they drink six sugary sodas a day. What do you tell them about artificially sweetened beverages?
Absolutely. So, when I talk about those types of drinks, the sodas in particular with diabetes, I say it's, a 1 + 1 = 17 as far as how bad it is for you. The empty calories and everything else that goes along with it, and what it does to your sugars, what it does to insulin resistance, what it does to the pancreatic function as far as insulin secretion. So, we really, that's a strong thing that we can do immediately, and I'm sure, Richard, you've seen this as well. You'll get that patient who's newly diagnosed and you just kind of go through a dietary inventory with them and say, all right, what are we eating? What are we drinking? Where can we make immediate improvements? And soda is one of those things that we see all of the time that, people have had a tendency to take into excess. And by immediately taking care of that, you can see a significant improvement, not only in their blood sugars, but oftentimes, I've had people getting 1,200, 1,500 calories a day, just completely empty calories with the soda. And by just eliminating that, you can go a long, long ways to improving things immediately. So that's one of the first things we try to eliminate, and look for healthy alternatives to, when we see that problem.
Yeah, and I've had patients ask me, I hear the aspartame in the diet soda is not healthy, and my take is usually it's a lot better than the sugar, and maybe we tackle that later. Is there any evidence that the artificial sweeteners have a negative impact on diabetes or anything like that, Richard?
I think the verdict is still out, but I'm also of the mindset, certainly at first switch them from the regular, sugared soda pops to diet, but then after that, kind of try to retrain your taste buds not to crave so many sweet things. So many of the artificial sweeteners are so sweet, and I think really I try to get them get on a carbonated beverage that really doesn't have any of the extra sweeteners in it. And if you like the carbonation, if you like your caffeine, honestly, coffee or tea, they're rich in antioxidants. They're probably more heart healthy than soda pop. So I try to steer them clear for that. But I don't know if we have true evidence about the sweeteners and effect on pancreas function and metabolism. There's some information, but really just to get them off the sugary stuff at first.
Yeah, good. We had a caller ask, what is a good, or let's say a normal fasting blood glucose level, and how do we keep it in healthy ranges? So, John, can you want to tackle that? What's normal?
Well, sure. So anything generally under 100 is what we would consider normal. So if a person does have normal glucose tolerance, that value should be less than 100. When you kind of get into that impaired glucose tolerance or the impaired fasting glucose range, I should say, and sometimes into that pre-diabetic range, you'll kind of see that number between 100 and 125. And then when we're seeing fasting glucose values greater than 126, that kind of falls into that range that's more consistent with the type 2 diabetes. As far as it depends on where you're at. If you've been diagnosed pre-diabetic, maybe at risk, but still have normal blood sugars, or if you have been diagnosed with type 2 diabetes, we'll have varying degrees of what our goal is for your blood sugars. And for some patients, we may be more aggressive if they're younger. If they're at lower risk, the medical treatments where we don't have to worry about low blood sugars, that we may try to strive for values of the low 100s. If we have older patients that are insulin treated, sometimes we're aiming for maybe 120 to 140. So that can vary depending on what your diagnosis is and how we're treating you, and maybe what your age is and risk of low blood sugars.
Yeah, good. So you mentioned low blood sugars. Richard, what is the problem with a low blood sugar? What can that cause?
It can be deadly. I mean, if it's severely low, it can cause heart arrhythmias. Certainly, the brain needs glucose to function, and when the glucose starts getting lower, below 50 or 40, that can actually cause cognitive impairment. If I have an elderly patient and they pass out and break a hip, it's not a good thing, right? So I think as much as we do aim for good control and tight control, you also have to watch for hypoglycemia. And that's where I think things like the continuous glucose monitors, which can alert the patient, especially some patients after years of diabetes, they lose the awareness. They get what's called hypoglycemic unawareness, and they don't feel it until it's dangerously low. And now that we've got tools that can help alarm or alert them to that, it's been really, really helpful.
Yeah. So what your approach when you make a therapeutic change, say you increase someone's insulin dose, what do you tell the patient? We'll see you in 3 months, but if you're having blood sugars of this low, call me, right?
Well, and doing and that's again where we're very fortunate to have nurses and health coaches. So I'll say, call me in 2 weeks, send me some readings, we're going to do this, but if you experience this earlier, by all means, call me sooner. And as John said, it might be different for that different patient. If I've got someone who's young and they're otherwise healthy and they've got the whole life, I'm going to try to be more intensive with control. If they're elderly and they've got multiple medical problems, I may not want to be as aggressive with my insulin, and that's okay.
Right, great. Well, technology used for the treatment of diabetes continues to evolve. Continuous glucose monitoring is the latest technology that helps track blood sugar constantly. Prairie Doc spoke with a pharmacist who shares the value of these monitors in today's world.
Every sensor looks like this.
Dr. Emily Van Kloppenberg is a pharmacist in Brookings who teaches patients how to monitor their blood sugar with a continuous glucose monitor.
It is a little system that we wear on the back of our arm that actually threads a little catheter underneath the skin that actually wicks up a different reading that's going to give us our blood sugar.
This monitor is applied in the fatty tissue region of the arm and monitors blood sugar levels more consistently than the classic finger poke.
So I only know what your blood sugar is exactly at the moment when you test your blood sugar through a finger poke. The nice thing with our glucose monitors is that we start seeing trends where it measures the blood sugar once every 5 minutes or once every minute.
This helps the patient with accurate, real-time data. Dr. Van Kloppenberg can see if food, exercise, or certain medication has dropped or spiked the blood sugar.
And then we're able to figure out what medications or insulin doses work best for that patient in that season of their life.
A pharmacist will help with the initial application, but the patient can take over once learned. This particular monitor lasts anywhere from 10 to 15 days and can be customizable for certain alarms like blood sugar spikes or when the monitor needs to be replaced.
Within the system, either the smartphone app or within the receiver, the patient will get alarms saying you are due to replace your sensor, and then they can replace it when it actually makes sense for them.
Dr. Van Klompenberg says these monitors are extremely accurate for checking blood sugar, especially for patients who have good blood sugar control and a low A1C.
5.5 and maybe up to 8, it is very, very accurate. It's when we get to someone who has really, really high blood sugars that sometimes we find that it's not as accurate, but also admitting that when someone has really high blood sugars, as a clinician, I'm going to note that as high, not as this is something I specifically need to look at that exact number. So I'm able to adjust medication still based off of that.
Dr. Van Klompenberg says the continuous glucose monitoring systems have been receiving better coverage by insurance and are becoming more affordable to people who need it.
For 2024, for South Dakota Medicaid, if you are on short-acting insulin or mealtime insulin, a continuous glucose monitor is covered. The other side is if you're on Medicare and on any type of insulin, generally these agents are covered underneath Medicare Part B.
Great segment. I imagine these devices have been pretty practice changing for you guys who see a ton of diabetes.
Very much.
And you mentioned really probably the hugest benefit in that patient who's at high risk of the low blood sugars and avoiding those bad complications.
That, and also I think lifestyle modification.
Yeah.
You know, patients will say, wow, I had no idea if I ate that hot dish that my sugars go up so much, so I know next time I'll do something different. So I think it really both to prevent and the lows, but also to modify behaviors that might have led to high readings. It's just so much more illuminating having that 24/7 data, seeing what they do in the middle of the night, seeing what they do after meals.
Yeah.
It has been a revolution for us.
I completely agree. I've had a few patients I can think of who we did nothing different with their medicine, but they got a CGM, and when they came back in 3 months, their A1C was a couple points better, just from the feedback that they get, right?
Right, and the lifestyle changes that they made.
Yeah, great. We've got a few more sort of lifestyle and prediabetes questions that maybe we'll hit before moving on to therapy and stuff like that. Let's see, how about, we had a question about fruit, so that's a great question, and this is something that maybe comes up with the dietitians. John, how about, we think of fruit as so healthy, but are there some fruits that we need to be mindful of when it comes to sugar intake?
No, absolutely, and that's a common question we get as well, and you'll get into the season where fruits are more plentiful, and you'll start to see hemoglobin A1Cs and blood sugars go up because patients sometimes have the idea in their head that this is healthy for me, this is fruits and vegetables, this is what I've always been told I should have. And it's like everything else, if it has sugar in it, you want to go forward with it in moderation, and so I try to steer people more towards the greens as much as we can, and fruit in moderation. But certainly we do see fruit sometimes negatively impacting blood sugars, and to the point of the CGM talk that we had earlier, that's where the continuous glucose monitoring with that type of diet really is helpful, because patients will say, I had no idea oranges did that to my blood sugars, or I had no idea that a banana would raise me 35 points on my Dexcom when I'm looking at it. So that's where not only the behavior, intentionally and cause and effect will come through, but I think even subconsciously patients start to change the way they're eating just based on what those monitors are telling them. And there can be some really enlightening things that patients otherwise thought was healthy, like the fruits, that maybe are causing their blood sugars to be higher than they should be. And this recently, having gone through watermelon season, several patients that will come to us with high blood sugars saying, I had no idea what watermelon did to me.
Yeah. How about, is coverage improving? I mean, sometimes the barrier to using these devices has been insurance coverage and the cost. What are you seeing with that, Richard?
I definitely think it is. And as the segment showed, with Medicare, if you are on insulin, and I think you do have to be on more than one injection, you multi-dose insulin, but that might include just what we call like a sliding scale plus some basal insulin, but they're very well covered for the CGMs. Like I say, South Dakota Medicaid is now covering it, many commercial insurances do, and so that I think has really opened up to many patients to get it. And certainly if you're somewhat on the fence because you think it might be too expensive, see what is covered and see some of them even out of pocket. There are several that you can do direct to consumer, just purchase out of pocket where it may be within your budget.
Yeah, great. We had an email question. My parents are both diabetics. Is there something that I can be doing to reduce my risk for getting it? John, what would you tell this viewer?
Well, making sure you're following regularly with your provider, getting your screening tests done, making sure we're keeping an eye on your sugars, and then doing everything you can from a diet and activity standpoint. And there doesn't have to be one activity or anything along those lines that you have to do, but just do what you enjoy. And I try to talk to patients with exercise. We all know it's not the funnest thing in the world sometimes to do, but find an activity that you like and be consistent with it. And I think that's the biggest thing is just get moving, find something that you enjoy and then be consistent doing it day after day or as many days a week as you can. Like Richard talked about earlier, making sure you're getting 150 minutes a week if you can. And then just really watching the diet, watching the weight, and just doing the best that you can to live a healthy lifestyle. And even sometimes patients that do that will still find that the genetic risk is such that they may come down with high blood sugars. That's okay. It's just so important that you're being screened so you're not one of those people who doesn't know that they're having the symptoms of diabetes. And that time starts ticking away as far as developing of risk because we simply haven't been watching for it.
Yeah, great. A couple of related questions here, so I'll just throw them out together. An email questions, I was recently diagnosed with prediabetes. Do I have to go on insulin, or I guess I would say on medication at all, or can I avoid that? And then a similar question, a viewer who got their A1C down from 7.0 to 6.1 with diet and exercise after a new diagnosis, would they still benefit by going on one of the diabetes medications? So now they're in that pre-diabetes range. Should we use medications in those pre-diabetic patients, or how do you counsel patients through that?
It's a great question. For the first part, the patient who has the pre-diabetes, what can I do to avoid medication? Yes, you may eventually need insulin, but for now, we talked about good diet and exercise, and if there's a bit of extra weight, even 5 to 10 pounds, they did this diabetes prevention program, and they found up to almost 50% delay over 3 to 4 years of developing diabetes with just those lifestyle interventions. And that group actually did better than a group that got metformin in terms of preventing diabetes. But sometimes there may be other problems that you have in your medical history that would warrant even with an A1C of 6.1, which we consider to be pretty good. If you had heart failure, you may want to use one of these SGLT2 medicines. If you had kidney disease, some of these have benefits kind of independent of where the blood sugar is. Fatty liver, maybe if your insurance would cover it, these GLP-1 receptor agonists that lower weight, maybe there's a benefit there, and also cardiovascular risk reduction. So you have to look at the whole picture and what the other medical problems are. For that patient.
Good. There's so many, we have such a huge population with prediabetes. I imagine this is an area of a lot of ongoing study. Is that true, John? What can we do to help this population?
Absolutely. And I think where we're seeing a lot of this data come from now too, where we can kind of extrapolate again, should we have early intervention? Should we be more aggressive? I think even for people that are early diagnosis of diabetes, with the standard of care being metformin, do we need more aggressive therapy? Should we use some of these newer agents? And I think what we're seeing in some of the weight loss medications, which are the very same types of molecules that we use for diabetes, the GLP-1s in particular that Richard referred to earlier, we're seeing initiation of these medications getting that significant weight loss, substantially reducing the risk of developing, diabetes and blood sugar issues going forward, just simply because of the weight loss. And so I think this perspective and this dynamic of therapy has really changed over the last decade. my perspective on it now is we should be aggressive right from the jump. We should try to get these patients on these medications that are not only going to lower their blood sugars as best we can, but they also are getting to the core problem of why they have diabetes. We're more than normalizing what's actually driving the diabetes to begin with. And so to me, I think we got to strike more aggressively in the early stages, certainly of type 2 diabetes, but even in the pre-diabetic range. Diet and lifestyle, those are always the most important first cog. But I think these medical therapeutics that we have now are really changing that conversation as far as, maybe if we're a little more aggressive up front, we can stave this off down the road. And I think that's the direction we're going to start moving towards as we start seeing the benefit from these GLP-1s and the weight loss that go with them, whether it's the pre-diabetic or even the at-risk patient for diabetes, as we go forward.
And especially probably in the younger adult patients who have a lot of decades of life in front of them, right?
Right.
Great. This is a great question. Richard, this email question, I have type 2 diabetes. Can I ever get rid of it? Do people graduate from type 2 diabetes?
It's a great question, and we do have some patients, for example, who have gone for bariatric surgery or and they've lost a lot of weight, and their numbers go down to what clearly are in a normal range. How do you define them? Because as John said, diabetes is a blood sugar fasting over 126 or an A1C of 6.5 or higher, and if they're consistently beyond that and no random sugars over 200, what do we call them? But I think the risks are still always there, and so still keep your weight down, keep your blood sugars down, keep your blood pressure under control, keep your cholesterol under control. The risk that we can't change the genetics yet, and so but if you want to think of yourself as no longer being diabetic, that might be a goal to strive for.
Yeah, great. Okay, let's talk about some of these other email questions, maybe some medication questions. So we had a caller ask earlier in the show, if I skip an evening meal, should I still take my metformin? And we've mentioned this drug a couple of times. John, can you just briefly tell us, what's metformin? Why do we use it so often? And then let's answer this guy's or gal's question.
No, absolutely. So metformin is probably the oldest medication that we still use. I think in Europe it was out even in the 80s, and I want to say in the United States it's been the mid 90s when it's been out. It's been the most tried and true medication that we've had over the decades, and certainly is the first step usually for when we're adding medications to manage diabetes on top of lifestyle modifications. Metformin basically works by reducing the amount of glucose that's being put out by the liver. And we know that patients with type 2 diabetes will inappropriately make a hormone called glucagon, which causes their liver to overproduce sugar. And we know through ways that aren't necessarily completely clear that metformin will work in the liver to help reduce the amount of that glucose coming from the liver. And so it's been a very safe medication, contrary to sometimes patients, and we were talking about this pre-show about how many questions we get about the safety of metformin. It is an incredibly safe medication, again, that we probably have more experience with than any other drug, currently on the market. And so, to answer the caller's question, if you miss the dose, metformin doesn't specifically have to be taken with a meal. Sometimes patients get better tolerability with it if they take it with food, so they don't get maybe the loose stools or the diarrhea that sometimes will go with it. But the beauty of metformin is it doesn't cause low blood sugar, and so you don't specifically have to eat if you miss a dose. That you could take it in the evening. And if you were concerned about it, though, you could certainly just start the next day with your regular dosing and get back on your normal schedule. So I don't think there's necessarily a right or wrong answer there, because you don't have to worry about getting low blood sugar with metformin.
Yeah, one of the many reasons we love that medication. We had an email question. Can we talk about whether Ozempic, semaglutide, is effective for patients with diabetes? So let's talk about this, class of medications. There's so much media on these medications for various reasons in the last year or two. How long have we been using these GLP-1 agonists in diabetes? And tell us about them a little bit.
Yeah, so they're called incretins, or the first one is what's called a glucagon-like peptide 1 agonist, and there's a newer one which is a dual GIP-GLP-1, tirzepatide or Mounjaro. But Ozempic, that class, the first one, exenatide, actually they discovered it in the venom of a Gila monster, which I think is so interesting. And that, I lose track, but it's at least been probably 15 years. So we do have a fairly long track record of using these medications, and we know that they work great great. They work to enhance the body's ability to make its own insulin in response to a meal. They slow gastric emptying, so you get kind of satiety, so maybe you don't eat as much, but also the glucose doesn't get secreted or excreted into the bloodstream as quickly, so it allows for fewer spikes in blood sugars. It works on the brain to probably inhibit appetite too, so we see weight benefits, we see definitely glucose benefits. Oftentimes if you have patients who are on insulin, you're able to even lower insulin doses because it kind of complements in a very smart way on off with the insulin in terms of how it works. So I think it's been a great advantage that we've got these. And again, now we're starting to see cardiovascular benefits, some other benefits that don't even relate to the blood sugar lowering. And with the weight loss and maybe lowering sleep apnea risk or hypertension or fatty liver, they're not without their problems, but they're really something that we are happy to have to use.
Yeah, for sure. Blindness is one of the adverse effects that people with diabetes can face. Prairie Doc visited an optometrist about what a diabetic exam is and why it is important as a part of your overall health plan.
Dr. Tasha Jones is an optometrist at 20/20 Family Vision in Brookings who performs diabetic eye exams for patients. Dr. Jones says the only difference between a regular and diabetic eye exam is the optometrist will look at the retina completely.
A diabetic eye exam is really a comprehensive eye exam where we look at the whole health of the eye. And so if someone does an eye exam without looking at the retina completely, you're not doing a diabetic eye exam.
Dr. Jones says diabetes can affect vision by fluctuating throughout the day.
They may have times of day where they see better in their glasses than others. And for a lot of people, that's kind of a good cue to them that their blood sugar might be off.
It's also a sign that a patient could have diabetes if they haven't been diagnosed previously.
If they get their glasses, they come back, they might say, well, these glasses aren't working for me, I can't see with them. And I recheck the prescription. And if I find a prescription that is very different, then we know there could be an issue.
If a patient's blood sugars aren't regulated, they could develop diabetic retinopathy. It creates swelling and hemorrhages that can distort vision in certain areas of the eye and could lead to blindness.
If you have diabetes and your blood sugar is too high, it's almost like a shard of glass going through your bloodstream. And if you have the disease for a long enough period of time, what can happen is the blood vessel can leak. And when that happens, when I look at the retina, I'll see small hemorrhages or areas of swelling.
Dr. Jones says the eye is unique because she can clearly see through the eye if diabetes is affecting the patient's vision. She relays that information to their primary care provider.
If I see changes and diabetic retinopathy is showing up, the medical doctor might need to make changes in their medications to get their blood sugar more controlled because we know there's now damage happening in the body. And if there's damage happening in the eye, it's likely happening in other parts of the body as well.
Great segment on the eye exam. I find this even probably more important. I mean, it's always been important, but we now have things that we can do for diabetic retinopathy to prevent blindness, right? So, I mean, if a patient is developing signs of that, it's really important to get them to the right place.
Correct, right.
Yeah.
Yep.
Great. Okay. We have a lot of questions, so we're just going to kind of fire through these questions and do our best to answer as many as we can in the remaining time. So we had an email question. A 54-year-old man diagnosed with diabetes a few years ago have started to get neuropathy mostly in their feet, which is getting worse. Is there anything to help? They see these ads for places promising good results to cure neuropathy. I get this question at least once a week in my clinic, I think, John. What are we seeing advertised, and what can be done for neuropathy? Can we cure neuropathy?
So there's a lot of options. You know, the first thing is always good blood sugar control. You know, and so the first thing we want to do is, particularly if your blood sugars are high, let's get things under control and let's kind of re-inventory your symptoms. How significant are they? Did they get better with better blood sugar control? Sometimes there can be some areas there of improvement just by virtue of getting the blood sugars better. Now, certainly neuropathy can be permanent, and if we get to that point, even after we've established good control, then we can start talking about, medical therapeutics, natural therapeutics. Generally, from a standpoint of medications, we have things like gabapentin or pregabalin, otherwise known as Lyrica. There's another one called duloxetine or Cymbalta that we'll sometimes use. As far as the supplements go and the things that you see advertised on TV, I think there is a certain extent of buyer beware, and one of the first questions I always ask patients when they come to me with this is, what's the cost? If this is an expensive treatment, where is it coming from? What are the ingredients? And I'll review it in the room with them, if we can figure out what the supplement is, just to see if there's going to be benefits. So I think a lot of those advertisements that you get, the issue with it is they probably haven't been studied in a vigorous fashion, like, the medications that we'll use, primarily in our clinic, prescription type medications, to where the claims that are being made may not necessarily be, what we actually see clinically. I think what I've seen from a neuropathy standpoint, though, particularly for those patients that have had the really life-altering neuropathy, where it's impacting their daily life, they're not able to be as active as they would like, they can't sleep at night because it's really bothering them. I've been working in tandem with our pain management doctors, and there's been a lot of breakthroughs as far as spinal stimulations and other modalities from that standpoint for patients who have had really refractory neuropathy that really hasn't responded to anything. Those patients have done a lot better, I think, than what we've done in years past. So I think there's a lot of hope for those folks, in the future if they really aren't responding well. So I would just always have that open dialogue with your provider. If you haven't tried some of the prescription strength medications, or if you have and they still aren't getting to where you want to be, that there are these other avenues now for management of neuropathy that we didn't have in years past.
Yeah, it can be a challenging problem. We had a caller who asked, can blood pressure medicine cause increases in blood sugars, for example, losartan and hydrochlorothiazide? Is this something that you think has any clout?
I think as terms of medications, cholesterol-lowering medications, statins do have some impact slightly on blood sugars, but I think the benefits outweigh the risk in terms of reducing heart attack and stroke risk. In terms of the blood pressure medications, again, losartan's what's called an ARB that has added benefit for kidney protection. So whether there's any effect, I don't really think of it as an effect, and if there was, I think the benefits for that purpose, outweigh any risk for that.
And not to my knowledge. I'm glad you brought up the statins, because I think that that's a challenging discussion, and really most of our guidelines support almost every adult with diabetes being on a statin. How do you coach? I mean, statins are something that gets a bad rap out there on the internet as well. So how do you coach your patients through that conversation?
I mean, they can have side effects, and they need to watch out for the muscle aches and things like that. But again, many people feel diabetes itself is the same risk for having a heart attack if you've already had like a bypass operation. It's what we call a risk equivalent, and that's why the guidelines are, regardless of where your cholesterol is starting out, is to try statin therapy. And there's some that can't tolerate it, but give it a go.
Yeah, good. We had a Facebook question. John, my husband has type 2 diabetes and he is a truck driver. What foods should he take on the road? And I guess what other sort of cautions do you present to patients that have that occupation? That can be a challenging situation too.
It's a very common thing we see. That's a great question, because if anybody who's done any traveling, whether it's in a truck or a minivan, the options on the highway aren't always the best when it comes for healthy eating. I oftentimes try to tell people to pack healthy, make your own lunch. Don't rely on where you're going to be as far as stopping at the truck stops or what have you. For patients that have type 2 diabetes, higher protein-based things, if you can do nuts, cheeses, those types of things that aren't going to have a lot of carbohydrates or sugars, that's going to be impactful for your blood sugar. And bring plenty of water. I think so many times on the road, people will also fall victim to maybe the less desirable things from a blood sugar standpoint, as far as sodas or those types of things. So pack healthy water, healthy sport drinks, things that are low in sugar. And just bring your own lunch. Don't rely on what's going to be on the road. Higher protein, lower carbohydrate, celery, those types of things as best we can. And and not go through the litany of fast food restaurants that litter our interstates.
Yeah, good advice. We had a Facebook question, Richard. Can your menstrual cycle and or going through menopause affect blood glucose levels?
It can, and we see that, especially our patients who are on continuous monitors, and you can kind of say, oh, that's kind of where the cycle is. And certainly with menopause, completely changes body composition, where you get more risk of what we call visceral adiposity, or more of the apple than the pear, I guess. You gain more weight there, and that's associated with insulin resistance. So all those are hormonal changes that can impact blood sugars.
Yeah, another thing that's not in your control. So
Right.
Come on in. We'll be understanding about it. We had a caller who asked, I swapped out Pepsi as a drink for V8, some vegetable juice, and it seems to have helped me. Is this beneficial? Or are there better options to help quit the soda? How would you advise this patient, John?
No, I think a thing like V8 is great. I mean, you're going to still have some carbohydrates, but you're going to have a lot of fiber. You're going to have, the nutrients, and there's a whole bunch of nutritional value, obviously, to something like that. And so I think you can see it also in your blood sugar values as well when you're seeing the differences between having a V8 and having a sugary soda. You're going to see some significant differences in those blood sugar values, and even for patients that still can't quite kick the habit, so to speak. That's where I really push making sure you're drinking plenty of water. Oftentimes if you can drink water to offset that, that need for continuously drinking things, I think patients will see benefit to it. So I think that would be a really healthy substitution, and again, in moderation like everything else, but it certainly beats the Pepsi for certain.
Yeah, probably look at the sodium on the label, especially if you have some other health issues, but a pretty good substitution. From email, we had a question, will insulin make me gain weight? Richard, what medicines might make people gain weight in diabetes, and how do you talk to them about insulin?
Yeah, I mean, insulin can cause weight gain. Insulin, and then the medicines, sulfonylureas, like glipizide, glimepiride, those type of medications among the diabetes class. And so you don't have to gain weight. You might have to make changes in diet and exercise, and certainly if you need insulin, you have to do it. But in general, it is probably more weight promoting. Something like metformin is weight neutral. Medicines like the SGLT2s like Farxiga, Jardiance, medicines like Ozempic, Mounjaro, those are typically weight loss with those.
Yeah, great. And I mean, just another reason, some people obviously need insulin and type 2 diabetes, but it's so nice that we have so many choices to lessen the insulin that we use in so many patients now. We had an email question. How do I make sure to get rid of ketones in my system after an illness? I guess as it relates to diabetes, John, what are ketones, and where do those come into play? Let's talk a little bit about type 1 diabetes, which we haven't talked a lot about.
Yeah, so type 1 diabetes is going to be far more frequent as far as the concern for ketoacidosis or ketone development. And really what happens in the situation of increased ketones, particularly in DKA or diabetic ketoacidosis, you're going to see it more commonly in type 1s. It can happen if blood sugars get too high or there's a relative insulin deficiency. So if patients stop taking their insulin for whatever reason, or blood sugars continue to climb, we need insulin to unlock basically the door to get glucose into the cells for fuel. And if we're unable to get that door open, and so we're not able to get the cells glucose, then we have to look for alternative forms of metabolism. That's when we start utilizing fats and proteins instead of glucose. And when we start doing that, that builds up an acid. And if that persists for too long, that acid can get to a critical threshold now where patients really become quite ill. And this is something that can happen in type 1 diabetics. If they get profoundly ill, we saw it a lot with COVID. You can see it with pneumonia. If patients stop taking insulin for whatever reason, they can slip into it easily as well. But we also see a fair number of type 2 diabetics where it can happen as well if they get profoundly ill. We do see it with some of the new medications that we have, as well with the SGLT2 inhibitors, those drugs like Jardiance or Farxiga. And while they're fantastic medications, if a patient with type 2 diabetes is on those medications and does become ill, we can even see it in those patients as well. And so if you have ketones, and if you're testing for ketones at home, Oftentimes if they're moderate or greater, we recommend that you call into your provider. And if they're not coming down with the proper, the proper treatment, whether that be adding correction doses of insulin or increasing hydration, then a person should come into the hospital and get seen and evaluated thoroughly to make certain that you aren't teetering on the verge of DKA, or if you are, that we get you treated appropriately, because that can be a life-threatening issue if it's not dealt with in an effective manner.
Yeah, good reminder. We had a Facebook question. We kind of talked about some neuropathy treatments, and this is another neuropathy question. I have severe shooting pain in my feet at night. I'm already taking gabapentin. Is there a topical treatment I could use also? Do you have anything that you recommend topically for your patients with neuropathy?
Historically, interestingly, we would sometimes use capsaicin, which is like the pepper, topical, and you think that would burn, but it actually sometimes deadens. Also, if there's any sort of like topical lidocaine or so, sometimes it's hard to get enough of an area with that to use. And so, but that's where I thought, like John mentioned, maybe that's when you go see a pain specialist and see if there are other blocks or options that they could do as well too. But if you're just on gabapentin, what is the dose? Is there room to increase that? Would you switch over to pregabalin or Lyrica? Would you add something like duloxetine? Sometimes we have to use several medications to get it controlled. So I wouldn't give up if you're just on the gabapentin.
Yeah, for sure, especially with nighttime symptoms. Usually what limits us with gabapentin is it makes people
fatigue,
drowsy,
right,
but if it's nighttime symptoms, then we can maybe be a little more aggressive. So great. We had a caller ask, are there any diabetes support groups in the Sioux Falls or Brookings area? Is there anything that you're aware of, Richard?
That'd be a great question. You could always call the Diabetic Education Center, and they might have some options.
I'm not aware of a support group in Brookings, but not a bad idea. We have plenty of patients that could fill a support group if someone was looking to start one. Another kind of neuropathy related question. John, could diabetes be causing the bottoms of my feet to itch at night?
Absolutely. That's a common symptom we see with neuropathy frequently, and so again, kind of like what Richard was talking about earlier, making sure you're on the appropriate therapeutics, topical things if you can get them to work. But that is a common symptom that patients will even complain the sheets on their bed is really enough to cause them the irritation to keep them from sleeping. And those are the things that we talk about all the time. If your neuropathy is impacting your ability to sleep or your ability to be physically active, that's when we need to step up the escalation of how we're managing things. And if what we're doing currently isn't working, we need to do more for you.
Yep, let's talk about it. Our winner tonight is Ben. A book will be sent to you shortly. We'll be back after this.
On Call with the Prairie Doc has been a leading source of health education for 22 seasons. Join us this season as we continue to provide health education based on science, built on trust. Follow us on Facebook, Instagram, YouTube, and TikTok to access the entire Prairie Doc library.
Thank you to our guests, Dr. Crawford and Dr. Palmer, for volunteering their time to help us learn more about diabetes. If you would like to see and hear more episodes of this program, please like and follow us on Facebook, Instagram, Threads, YouTube, and TikTok, or visit us at prairiedoc.org. Look for Prairie Doc Perspectives in your local newspaper and online. Listen to us on Prairie Doc Radio on SDPB Sundays at 6 a.m. and 1 p.m. And be sure to look for the podcast of this program, Prairie Doc On Call, wherever podcasts can be found. From all of us here at On Call with the Prairie Doc, thanks for joining us for another episode of health information based on science, built on trust. Until next time, stay healthy out there, people.
Head and neck cancer develops in the mouth, throat, nose, and salivary glands and affects individuals' quality of life and ability to function on a day-to-day basis. Head and neck cancer, next time on Call with the Prairie Doc.
Hi, my name is Joni Holm, and I serve on the Healing Words Foundation board, the nonprofit that runs the Prairie Doc programming. Our mission is to enhance health and diminish suffering by communicating useful science-based information respectfully and compassionately. Your donation supporting Prairie Doc programming makes an extraordinary difference. Gifts of any size enhance its impact in our state and beyond. Thank you for your generosity.
Major funding for On Call with the Prairie Doc has been provided by
At Avera, our nationally recognized health system will be right here with you, with care and coverage. Hello possibility. Hello healthy. Hello life. Avera, moving health forward.
Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information. And with the ongoing support of these individuals and institutions, Brookings Health System, South Dakota Academy of Family Physicians, Ophthalmology Limited, Avera Medical Group Brookings, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Monument Health,